Hi, my name is Candace Benner, and I am a family nurse practitioner who has subspecialized in ears, nose, and throat for the last 14 years. You are getting ready to view the second of 5 modules that I have created to help nurse practitioners and physician's assistants evaluate common ears, nose, and throat complaints. Upon completion of this module, the clinician will be able to identify the types of tinnitus that warrant a workup, identify an appropriate plan of care based on the diagnosis, and lastly, educate the patient on lifestyle changes that may help with their ability to adapt to the tinnitus. I hope you find this module helpful. Tinnitus is commonly associated with hearing loss and is a perception of sounds heard by the patient in the absence of an external source. Tinnitus can be classified as subjective or objective. And subjective tinnitus can be further divided into the following categories: otologic, neurologic, and psychologic. Objective tinnitus can be further divided into vascular abnormalities, dental defects, as well as eustachian tube dysfunction. When a patient presents to the clinician's office, the clinician should consider subjective tinnitus to be possibly otologic. This would include ototoxic drugs such as aspirin, aminoglycoside antibiotics, nonsteroidals, loop diuretics, caffeine, and alcohol intake, as well as the use of cocaine and marijuana. Depending on the patient's age, the clinician may need to consider age-related hearing loss, also known as presbycusis. Noise-induced hearing loss is not uncommon. Patient's occupational history, hobbies, as well as time in the armed service should be questioned, as well as, depending on the patient's additional symptoms, Meniere's disease may need to be ruled out. Under neurologic, acoustic neuroma may be a possibility, particularly if it is associated with unilateral tinnitus with or without hearing loss, poor speech discrimination, as well as additional vestibular symptoms. If the clinician highly suspects an acoustic neuroma, an MRI of the brain, post-or faucet IACs with or without gadolinium should be obtained. Patients who suffer from significant tinnitus that is constant in nature oftentimes will also have associated depression and anxiety. The clinician may need to make a referral for psychiatric evaluation if unable to find effective coping mechanisms for the patient to utilize. Objective tinnitus, the clinician should consider vascular abnormalities such as arteriovascular malformation, glomus tumor, stenotic carotid artery, or dehiscent jugular bulb, particularly if the patient is complaining of pulsatile tinnitus that keeps rhythm with the heartbeat, hearing being diminished because of the intensity of the tinnitus. Glomus tumor is typically observed on physical exam of the middle ear space. It's blue in color. An arterial bruit or venous hum is heard upon auscultation. Dental issues such as temporomandibular joint syndrome is oftentimes associated with tinnitus, and this can be made worse if the patient juts their jaw out forward or moves it from side to side. Clinicians may notice popping or clicking with manipulation of the temporomandibular joint, as well as pain with palpation to the joint and the masseter muscles. Patchless eustachian tube is typically observed by the clinician under the binocular microscopy with fluttering to the tympanic membrane with respirations. The patient may complain of autophony, a roar of the ocean, or that their hearing seems to be muffled or they're in a tunnel when they talk. In a report by Munda, Singha, and Lingam, published in 2015, a CT, arteriogram, and venogram has been able to demonstrate in detail the relationship of arteries and veins of the head and neck, as well as the dural venous sinus. The CT includes high resolution of reconstructed bone images, which is useful in detecting osseous dehiscence and pathology in the temporal bone, middle ear cleft, and the skull base. In addition, the CT-AV was useful in detecting dural arteriovenous fistulas. Temporomandibular syndrome is a multifactorial syndrome and which may be caused by myofascial pain in the muscles that control jaw function. Internal derangement of the joint may be present in addition to dislocation of the jaw or injury to the condyle. Lastly, arthritic changes including degeneration and inflammation can be part of the syndrome. Treatment of TMJ syndrome starts conservatively, including the use of heat and cold compresses, dietary changes such as using soft foods and avoid chewing gum or hard candy. Also, techniques to reduce stress, use of nonsteroidals, muscle relaxants, and stabilization splints, also known as bite guards. At the end of this module, I have provided a list of recommended readings that will hopefully answer any additional questions you may have. I hope you have found this video to be helpful in narrowing down the list of differential diagnoses associated with tinnitus.